Thank you again for joining us for the Oley Foundation webinar, Recent Advances in Vascular Access. My name is Andrea Guidi. I am the Executive Assistant for the Oley Foundation. Most of you are probably familiar with the Oley Foundation, but just in case this is your first experience, I'd like to briefly introduce the organization. The Oley Foundation strives to enrich the lives of those living with home nutrition support, both intravenous nutrition, sometimes called HPN or TPN, and tube feeding. We do this through education, outreach, and networking. The Oley Foundation was founded in 1983 by Dr. Lynn Howard and her patient Clarence Oley Oldenburg. Today we serve approximately 17,000 members. All of our programs are free of charge for patients and their families. First, we'll go through a few housekeeping details. You should see a toolbar on the right side of your screen. Click on the orange arrow to show the control panel. In the question section, you can type any questions you have for me or for the presenter. Please note we will not be responding to the hand-raising function in the control panel. We will answer as many of the questions as possible during the questions and answers period at the end of the presentation. We'll post a recording of the presentation and handouts after the webinar on the Oley website. Please note that we have muted all of the participants, so you don't need to worry if there's any background noise where you are taking this webinar. If you are having technical issues, please go to the Citrix website at the address on your screen. And now for the presentation. It gives me great pleasure to introduce today's presenter, Dr. Robert Lookstein. Dr. Lookstein is Professor of Radiology and Surgery in the Division of Vascular and Interventional Radiology at Icahn School of Medicine at Mount Sinai. After attending medical school at the State University of New York, SUNY Health Science Center at Brooklyn in 1995, he completed his radiology residency and fellowship in vascular interventional radiology at ISMMS in New York. He subsequently joined the Division of Vascular and Interventional Radiology as faculty in 2002. Dr. Lookstein currently lectures around the world on various subjects in the field of vascular and interventional radiology, including peripheral arterial imaging and intervention, endovascular interventions, aortic stent grafts, and deep vein thrombosis. He is recognized as an innovator in the field of peripheral vascular disease and non-invasive vascular imaging. His clinical practice is focused on the diagnosis and treatment of peripheral vascular disease. Dr. Lookstein currently serves as Vice Chairman in the Department of Radiology, overseeing all interventional services for the Mount Sinai Health System. He is a member of the Steering Committee of the American Heart Association's Council on Peripheral Vascular Disease. Dr. Lookstein serves as the Chair of the Society of Interventional Radiology, Service Line for Peripheral Arterial Disease. He is a regular faculty member of numerous national and international meetings, including the International Society of Endovascular Therapy, Advanced International Management, the Society of Interventional Radiology Annual Scientific Meeting, the Radiologic Society of North America, and the American Heart Association, the IVA, the Transcatheter Cardiovascular Therapeutics. He is the course program director of several national education courses, including Lower Extremity Arterial Revascularization, LEARN, Transradial Endovascular Therapy, TREAT. Dr. Lookstein is the clinical director and chief of the Division of Interventional Radiology. He serves on numerous committees within the Mount Sinai Health System related to patient safety and quality, novel procedure oversight, cardiovascular disease, intervention value analysis, and performance improvement. We are thankful to have you presenting with us today, Dr. Lookstein, and I will turn the presentation over to you now.
Okay, thank you, Andrea, for that very kind introduction. I'm going to, get my slides up. I'm hoping everybody can see my slides.
Perfect, now we can.
Awesome. As Andrea said, I'm an interventional radiologist, and I've been very, very fortunate to have tremendous clinical partners in our institution here in New York City that are focused on the care and safety of patients with nutritional access issues. And this ongoing collaboration has really led to what I believe to be a very advanced clinical experience and the development and implementation of a culture regarding optimizing patient outcomes with difficult central venous access. What I'm proposing to spend the next 30 minutes on or so is describing what I consider to be state-of-the-art advances in maintaining traditional central venous access as an alternative to non-traditional central venous access. I'm going to try and make this not too technical, but try and give you a perspective of what we deal with here at Mount Sinai on a weekly basis to try and offer safe, durable access for our patients that require long-term indwelling central venous catheters. So without any further interruption, these are my disclosures. I serve as a consultant for medical device companies, including companies that manufacture and distribute central venous access catheters. Most importantly, I think when we try and discuss how to optimize and maintain central venous access, for all the people in the audience that are dealing with this firsthand, it is really imperative that your providers of care are considered experts in central venous anatomy. This is absolutely critical. You truly cannot be cared for by somebody who dabbles in this. You need somebody with a broad scope of practice, somebody, again, who has formal training in vascular anatomy, vascular imaging, vascular therapy, because as I'm going to demonstrate to you, when we deal with challenging patient subsets, unless you understand the anatomy intimately and not just as a sort of cartoon that I've demonstrated here from an anatomic textbook, but really three-dimensional anatomy, unfortunately, you're really not going to get the best outcomes. I would argue that patient care is not going to be as safe as you would like it, and you're going to be deprived what I would consider to be state-of-the-art options to improve a patient's quality of life. So you really need expertise in terms of understanding vascular anatomy and understanding how to image it. So I would say that my group gets called, if not weekly, probably every other day, so well over 150 times a year, there's a patient in the building that has very bad access, that a medical provider who is considered first-line staff for maintaining vascular access is unable to create central venous access, and we're being consulted to optimize the patient's access. And so from the initial thing that we do, because we understand our frontline staff, what their limitations are, what their technical skill set is, but the most common clinical situation is that another member of the faculty here within the hospital, which are typically surgical faculty, try to place a central line of some variety, and they technically fail. And again, these are people I've worked with for better part of 10 years, so I really know where their strengths and where their weaknesses are, and I have the utmost respect for them. They have obviously a good understanding about where my expertise is, and they feel very comfortable when they're in challenging circumstances to contact me directly. And the conversation is very uniform. It is very standardized for every patient, regardless of what their medical comorbidities are. But we essentially say, do we know what their central venous anatomy is? And if the answer to that question is no, we very rapidly will recommend that the patient have a CT venogram. A CT venogram is essentially a standard CAT scan of the chest, which is protocoled to specifically visualize and identify all the venous structures within the thoracic cage. And depending on how complex the patient's history is, we may expand that to include the abdominal and pelvic circulation to make sure that we have a true view of the entire torso, to explore all vascular options. But simplistically, for the purposes of central venous access, we're really looking at the chest. I'm not going to go into the radiology subtleties here, but for anybody with a medical background, we really make sure that the imaging data set is a true three-dimensional data set, because this is critical for therapy planning, especially when we get into complex central venous access. And these are some of the representative images that we're able to obtain. And so some people might be oriented with this image here that I'm highlighting in the lower right, where you actually are able to see the collarbone, the clavicle, the ribs here. And what we've delineated is essentially where all the veins are in the chest. And again, for anybody with a medical background, very, very few of these veins look normal. This left-sided vein here is more normal, but there's really nothing that I would consider a standard named vein on the right side. The superior vena cava, which is a large vein that decompresses the chest and the arms, appears to be patent in the chest. But just as an example, if we were fully committed to create a right-sided chest access or a right neck access, this would be considered to be very, very challenging. When we go into the source data here, and just to orient everybody, this is the front of the patient's chest. This is the back here. This is the actual spinal column. The dark areas here are the air within the lungs. What we see here is typically we want to see a very, very large vein in this anatomic region, which I'm highlighting, which there's no contrast. There's none of these sort of white lines, which are opacified veins, with intravenous contrast being opacified here. There's no normal anatomy in this portion of the chest. And so it's absolutely critical to be able to determine how we're going to get a catheter from a patient's chest wall down to these central structures here. And in my humble opinion, CT is the only reproducible way to be able to do that. Not only can my team interpret this data, but if we need to collaborate with our surgical colleagues, they can understand this data very, very rapidly. It is available at almost any hospital in the United States, with not a tremendous deviance from routine clinical practice. And so if you have a modicum of infrastructure, you can obtain images that look like this and be able to guide therapy moving forward. Here's just another example, again, a standard CT data set of the chest here. This is the aorta, again, not relevant for venous anatomy, but there's not one vein that is visualized around the entire aorta. So there's no named vein in the entire chest. Very, very complex central venous access. Alternatively, all we see are collaterals that are opacified within the chest wall. And again, this is just one slice, but reconstructing this as a three-dimensional roadmap allows us to come up with options to present to the patient to be able to facilitate giving them a more traditional venous access. Once we have the CT data set, we can plan how we're going to perform what would be considered a more traditional venogram, which is where we actually have the patient in an X-ray room, and we will inject dye through a peripheral vein to be able to opacify the chest here. This is obviously the gold standard diagnostic study, but I would argue in our cases, we never proceed with this without having a CAT scan to make sure that the venogram can be performed in a very rapid manner to facilitate catheter placement. We need to plan where the occlusions are ahead of time, be able to plan for angioplasty and stent placement through the occlusions that will likely exist for these complex cases. And as I demonstrated on the previous images, anytime you see collaterals or a lock of contrast filling a named standard anatomic vein on the chest, that is a diagnostic that's pathognomonic for a central venous occlusion, which is really the sort of bane of everyone's existence here that we're trying to overcome. When we perform conventional venogram, these are the images that we will typically obtain. So this is a fluoroscopic image. The dark tubular areas are contrast injected into the central veins. This is from a right subclavian vein injection, and you see the contrast column cuts off abruptly, leading into the superior vena cava here and downward into the right atrium. So this patient is completely occluded here for about 3 or 4 centimeters. There's a very short thread here of a jugular vein, but likely this access failed, and we're trying to figure out how we can create an access here, either from the external jugular vein into the superior vena cava, and essentially bridge this gap and reconstruct it. Another example on the left side, similar anatomy, the axillary and subclavian vein are open. There's a 90% narrowing of the mid subclavian vein before it becomes the brachiocephalic vein. A very common problem that we have is for patients with pacemakers or defibrillators. You can see scar tissue build up on these wires, leading to a tight narrowing here before again becoming the brachiocephalic vein. A 90% narrowing of the distal brachiocephalic vein on the right side before it enters the superior vena cava, which can obviously make it very difficult to place central venous access. Here's a patient with no right-sided venous anatomy that is normal, almost no normal left-sided venous anatomy, and in addition to that, the superior vena cava is completely occluded, a very challenging case to try and maintain, try and create and maintain central venous access. Patient with a 90% superior vena cava narrowing, and probably one of the worst cases I've ever seen. Somebody with no subclavian veins, no jugular veins, no brachiocephalic veins, and then only very, very, very distally do we see something that remotely resembles a superior vena cava here, but clearly a very, very challenging case. And unfortunately, this was a pediatric patient who was going to require long-term venous access due to short gut. And so we really needed to be creative to try and find this patient a vein to maintain central venous access. So when we're diagnosing this, we realize that this is very, very common in the short gut population. These, as we all know, patients get central venous catheters routinely, and these catheters are have a high predilection for sclerosing and occluding the central veins. It's important to diagnose where the occlusion is. You want to be under the care of a vascular specialist, but most importantly, you need a 3-dimensional imaging data set in order to plan therapy. And I would argue that we would never entertain creating a new access, hopefully a traditional central venous access, until we've gone through this entire exercise of mapping everything out. To shift gears to access creation, not just diagnosis of where the occlusions are, I think, again, everybody on the call is familiar with what I would call alternative accesses. And this is something that we used to place routinely in our practice, probably at least 1 or 2 a month. And this is a transhepatic Hickman in the image here on the right, with the catheter tip going through the rib cage with the tip of the catheter in the right atrium. This is a translumbar line. This is a dual lumen Hickman being placed through the patient's right back, going up into the right atrium here. This is going through the inferior vena cava to progress up into the right atrium. We perform these procedures routinely, I would say, until about 6-7 years ago. And what we found was that these catheters specifically were associated with high rates of morbidity, sepsis, bleeding complications, and probably even more important than all those issues I just mentioned, the patients were extremely unhappy with these accesses as a routine. And we really needed to put our minds together as a team across the surgical and radiologic staff to try and overcome these problems. The issues that we were having at Mount Sinai were not unique to us. These references that I've listed here replicate our experience, where you have very, very high morbidity on the order of 20 to 30%, after 12 months, very high rates of sepsis, very, very poor patient compliance, very high rates of patient dissatisfaction. And again, we really said that we needed to modernize our practice, bring ourselves into the 21st century, and adopt what I would consider to be contemporary techniques for establishing conventional central venous access. So again, just to summarize, these alternative accesses, in our experience, were associated with high rates of infection, bleeding, inappropriate manipulation, inadvertent arterial injury leading to morbidity with intra-abdominal bleeding. And we felt we needed to get much more creative at maintaining upper body central venous access. And what we did was we decided that we were going to come together as a team and create a standardized approach for performing all of these advanced cases. And I'll just give you a little tour of these advanced techniques that we've been able to establish. Just to describe a couple of common themes when we decide we're going to do one of these cases, all of our patients routinely, without compromise or under general anesthesia, we do not feel it's safe to proceed, and I'll explain to you why in a few moments. But everybody's under general anesthesia for these cases. All the patient's extremities are prepped and draped, including their neck, their arms, and their legs. And we typically, for these cases, will have multiple accesses. I would say commonly we'll have 3 access points, but I've had cases where we've had many as 5 access points. So that's one of the reasons why a patient is really best suited to be asleep for this. But we really need to be very open-minded in our scope. This is absolutely critical for these kinds of cases to have everything mapped out ahead of time and to have a plan. I cannot emphasize enough to be sort of making this up on the spot for these kinds of cases is really not in the patient's best interest. You can take a case that should be able to be completed in about 60 or 90 minutes and turn it into a 3 or 4 hour procedure, which in my opinion is not acceptable for patient safety. I'm not going to belabor the point about the toolbox, but you really want to be in a very advanced lab that has a variety of different types of equipment. And we have refined this toolbox over the years, but probably the most important thing from a contemporary point of view is this concept here in the lower left, which includes sharp recanalization. And I think this has really been the disruptor in the last 5 to 10 years, where we are being able to cross long venous occlusions using needles delivered through the chest in now what I would consider to be a safe technique, and then supporting crossing these occlusions with balloons and stents to facilitate access at a later date. But there's a variety of different catheters that you really need to have. Again, I'm not going to go into this too much, but you really need to have a standard toolkit that's available, and it should be standardized for every advanced case that you do. So just to go through the cases, very rapidly, this is a case that came in from an outside institution. The patient presented with superior vena cava syndrome. You can see that the head of the neck is very, very swollen. A right-sided stent had been placed, which had jailed out the entire right side of the neck. The stent was occluded, and it had jailed out the left side. And we were committed to opening up the patient's left side due to the morbidity associated with the right-sided crossing. And traditionally, we would view this as being something where we would not be able to cross because the stent had jailed us out. But using sharp techniques, we were able to open this up. You can see the stented segment here on the left side. And almost immediately after the procedure, the patient's head is decompressed. He is what I would consider asymptomatic. We were able to place in a central line, and the patient is very happy. That is more of a routine case where we feel that an old stent should not preclude us from maintaining access to the central veins of the chest. Here's another example of a patient with an indwelling catheter leading to venous occlusion, a very symptomatic, again, presentation where the patient's neck and right arm are quite swollen. But again, using contemporary techniques, We were able to access the patient's right arm, place a needle, as you can see here, and we have dedicated needles for this, into the central veins of the chest, open up the right-sided circulation, and decompress the patient's symptoms. We were able to maintain venous access on the left side. The patient's swelling goes down dramatically, and this procedure in total took about 45 minutes. And again, this is the before and the after. So dramatic results that we're able to see here. This was our initial introduction into this concept. We were able to, for the most symptomatic patients, achieve relief of their symptoms, maintain central venous access, restore circulation to the central veins of the chest, and obviously just improve their quality of life moving forward. Here's a little bit more of an advanced case, and I'll try and explain to you what we're doing here. This patient has, no real access on the left side for us to get into. The right-sided veins that are here on the right side of the chest are completely occluded. And what we have now is we have access from the legs, placing catheters into the chest. We have access from the patient's right arm. And what we've done is we've essentially placed a target for this needle that we've introduced from the patient's arm. We're trying to advance the needle into the target. We use three-dimensional imaging techniques to triangulate the target. Once we're able to capture the target, we're able to successfully cross and stent open these central veins. Once the central veins are open, we can place catheters, again, typically through the external jugular vein, or even place another catheter here on the left side once everything's been restored. But this is a routine setup where we will have a target within the central veins of the chest, or we'll have a target in the veins of the arm, and we're using essentially needles to cross through the occlusions from the top down to the target, or from the bottom up to a target that's been inserted into the veins past the point of occlusion in the neck or in the arm here. Another case here with an occluded vein in the chest, an occluded arm with venous hypertension in the arm, and then after the vein's been recanalized, the arm is able to decompress and the patient's symptoms have resolved dramatically. There is not a wealth of literature regarding these advanced techniques. I cannot emphasize this enough. It's unfortunate, and my group is going through our own exercises now to organize our data in a way to disseminate this, hopefully share our experiences. But this is, I think, two publications that are truly reflective of what the current state of the art is. The first publication is on the top of the image, which is a dialysis experience published in 2016, which is typically going to be reflecting an experience from 5 or 6 years ago, where once they adopted a routine use of sharp needle recanalization, they were able to cross 100% of the cases, but they had 28% major complications. And you might say, well, that's very encouraging that they can open up 100% of the central veins of the chest, but what are these complications? So I'm here to tell you that the complications are not trivial. They are major. They are most commonly bleeding complications within the chest. And in this series at the top, actually 2 patients expired or suffered a mortality as a direct result of these procedures within the 30-day following these procedures. And so I would view this top paper, this top manuscript, as a starting point. And the perspective that I would give is that if the operators are going to be very, very aggressive and they're going to use every tool in their toolbox, perhaps without the appropriate level of procedural planning, they can cross anything, but there's going to be a trade-off of very significant morbidity that will be passed on to the patient as a result. Which brings me to my next reference here, which is the second reference on the screen, which is an experience that was literally just published this month, which is a more of a, I think, reflective experience of the demographic that's on this call, which includes some dialysis patients, but a lot of short gut patients that require chronic parenteral nutrition. And I would argue that this group that's referenced here on the bottom, which is an American group, several of these physicians I've actually trained myself, they are firm believers in pre-procedural planning with three-dimensional imaging. And I think what their experience shows is that when you truly plan the cases compulsively and thoughtfully, you can most importantly improve the safety of these procedures and lower the major morbidity down to 5%, which really translates in this case, in this series, to a couple of patients that needed blood transfusions and had perhaps prolonged stays in the hospital. There were no mortalities and no other major morbidities associated with this experience. And the trade-off there was that they were not able to successfully cross every single case. They knew perhaps when to stop, because they knew that if they were going to continue with the procedure, that they would likely double the major complication rate, or God forbid, triple the major complication rate. And I would argue that this experience from this publication, again, sort of hot off the press, if you will, is really what we're talking about right now. And if you have a group of physicians that are thoughtful, that value pre-procedural planning, you should be able to successfully cross 95% of central venous occlusions, restore conventional central venous access to this patient population, and bring the major complication rates down to a very, very low basis. And I would argue a 5% major complication rate is at the level that most centers would describe for transhepatic or translumbar access. And I think we would all agree on the call that every patient almost exclusively would prefer to have a conventional central vein chest access as compared to transhepatic or translumbar access. And I think this is really where state-of-the-art therapy is for the compromised central venous access patient is. So again, here's some slightly more advanced techniques with contemporary tools. This is, again, a very challenging case. The jugular veins occluded, the subclavian veins occluded, the brachiocephalic veins occluded. This patient had failed numerous operators trying to maintain central venous access. In this case, we had 3 separate accesses, one from the right arm, and both femoral veins to set this up. Again, notice the patient's under general anesthesia. And what we were able to do was, again, introduce a target into the chest that we would use a sharp needling tool. We're just sort of getting everything into place here. And just a slight variation on the previous themes that I've showed you, we were actually able to introduce a balloon into these veins. And this is a device that has a micro needle attached to it to, again, improve the safety of the procedure. And the micro needle is advanced into the balloon directly, and then a guide wire is introduced into the balloon. The balloon essentially captures the guide wire, and the guide wire is facilitated down into the chest to make the procedure just safer over time. And this was the end result, and this patient did very, very well. We happen to be a site here at Mount Sinai where we are fairly liberal with stent placement, so it's very, very common that a patient, after undergoing a central venous recanalization, will have a stent placed. I find this is better for the patient in the long term because we become very, very comfortable at crossing stents when they've occluded, and we feel that that is a safer effort than using these advanced needle techniques time and time again. If the vein were to occlude over time, we essentially use the stents as a landmark to facilitate crossing at a later date. Here's just another example. Similarly, the subclavian brachiocephalic vein and superior vena cava are completely occluded here. This is another variation on the theme. We've put micro targets in from the arm, micro targets in through the chest, and then through the patient's skin, we place a micro needle to again decrease the morbidity and improve the safety through one target, through the second target, and then at the end of this Sinai loop, you can see the guide wire coming out. And by this way, externally, we're able to communicate the veins of the chest with the veins of the arm and then facilitate central venous access. Here's the guide wire essentially now being introduced from the leg veins through the chest, out through the arm. And then here's the stent placement, and then we can place a catheter through the external jugular vein here, through the chest into the superior vena cava. And this we can access at any point later on if due to unforeseen circumstances, the catheter needs to be removed. I cannot emphasize this enough. Good preoperative imaging, which is why I started this talk, demonstrating the benefits of good preoperative imaging, is absolutely paramount to knowing how you can set up your case. The basic concepts I've alluded to here: you need a target on one side and a needle on the other side. We have moved away from using very large needles to reduce the morbidity to these micro needles. And we've also gotten into a more traditional workflow where we're using covered stents, because we have some preliminary data that show that stents that are covered with bypass fabric reduce the morbidity of these procedures, stop any internal bleeding. And so that is evolving into what I would consider to be our strategy for 2017 and 2018. And so again, not to belabor the point, but these are the two different setups. We either have a target in the arm and the needle goes from the vein in the leg through the chest up to the target in the arm, or we have a target in the chest and we're able to position the needle pointing down into the chest. This is my own editorial. If the needle is inserted through the vein in the leg and goes out the chest up to the arm, that decreases the risk of bleeding into the chest, and the most devastating complication is cardiac tamponade, which can be life-threatening. You do need to be meticulous. You really do need to have the patient asleep for this. Some operators prefer to send the needle down from the top. We found that increases the risk of bleeding into the chest, and we have largely shied away from this. In some circumstances, this is the only way to facilitate completion of the procedure, but we truly use this as our last resort. And so this is just how we conceptualize this. So we prefer to go sort of bottom up, sort of advancing the needle out of the chest towards the arm, instead of going top down, advancing the needle from the arm or from the neck into the chest. And it's purely based on a risk assessment. Another intriguing technology is a relatively novel technology, which is a guide wire, which is even smaller than the micro needles I just showed, which is hooked up to an electrical generator, and it generates an electrical current at the tip of the guide wire. Requires a little bit more of a capital investment within the hospital and within the lab that is performing these procedures, slightly different setup. But essentially, once the guide wire reaches the occlusion, the electrical current will more or less, using thermal energy, almost burn through the occlusion and come out the other side. As you might imagine, this really needs to be performed in the safest circumstances. We've done several of these cases. We're adamant these need to be done under general anesthesia. This guide wire, once it's activated, will really go through any tissue. And if it's performed without compulsive pre-procedural planning, can be associated with untoward risk to the patient. So we have used this on several instances, but again, we mandate compulsive pre-procedural planning for these cases. This is just an example where this technology was used. Large central vein occlusion on the right of the brachiocephalic vein leading to the superior vena cava. Large central venous occlusion on the left, much even longer than it was on the right. And here, this activated guide wire, the radiofrequency guide wire, was advanced from the top down to the target in the chest on the right side. We chose top down because it was a very short distance to pass, and we actually failed technically going bottom up, but we were able to cross through and again reconstruct the central veins, and this will allow us to place a jugular line in this patient and again maintain more conventional central venous access. This is that case I showed you before. It's probably one of the worst cases we've ever seen. Every single vein is completely occluded on the left side. The jugular vein on the right side dumps into a completely inverted collateral here. Only the distal subclavian vein is open. The superior vena cava is completely occluded. And again, if you can't tell from the x-rays, this is a very young child, I believe about 6 years old, 7 years old. This patient was on the small bowel transplant list and clearly needed to have central venous access to facilitate parenteral nutrition for the foreseeable future. And this really mandated that we get very creative with pre-procedural planning and procedural execution to make sure that this young child was going to be safe and sound. Here, as I alluded to before, we performed a sharp needle recanalization from the bottom up, and you can see this this needle, which looks large in this child, but this is actually a micro needle being introduced into a target inserted up into that vein in the chest here. Once we crossed, we placed a large central venous stent, and by miracle, we were able to place a dual lumen Hickman tunneled catheter into this child's chest, and the patient was able to resume parenteral nutrition immediately. And not 6 months after this procedure was completed, the patient underwent successful small bowel transplantation, is actually doing very, very well. So we're even performing these procedures for a pediatric population, but again, it's really predicated on our ability to plan these cases and execute them in the safest fashion possible. This is a abstract that we presented publicly at the International Transplant Congress 5 years ago now. Our conclusions of the abstract are that aggressive attempts at sharp needle recanalization can regain conventional upper extremity central venous access, and only when those fail do we move towards transhepatic or translumbar access. Our experience in this paper, which is again 5 years ago, we only had a 55% technical success rate with no major complications. In preparation for this talk and numerous talks I'm giving over the course of this year on this topic, I've re-examined our own internal data, and so we are now up to 95% technical success with 7% major complications. And actually, the last major complication we had was in 2016. So our experience has been even safer in the last 12 to 15 months. But I think this is really where very experienced centers are migrating towards, where with the use of modern techniques, modern technology, compulsive pre-procedural planning, we're able to create and maintain conventional central venous access in 95% of the patients. Our morbidity rates are going down and down and down every single year. We have not had a mortality ever in our experience as related to these advanced techniques. We have had bleeding complications, and that's represented here in these major complications. And so that is really the trade-off for our ability to maintain these accesses, that we do associate the accesses with a very, very low rate of morbidity, but in our experience, we feel it's worth it for the patient in the long run. And so that's my presentation. I'm happy to take any questions now from the audience. I think, Andrea, I'm going to hand the podium back to you. so we can go back to your screensaver, and I'll just sort of field questions as they come through.
Excellent. Now we can begin the question and answer sessions of the webinar. And if you haven't already done so, please feel free to submit your questions in the question section of the toolbar on the right side of your screen. We'll do our best to answer as many of the questions as possible. We do have some coming in already. Our first one, Dr. Lookstein, is what is the optimal type and number of lumens of a long-term venous access device for the home parenteral nutrition patient?
So as a general concept, the lower number of the lumens, the better. And we found that not that there's such a divergence, but given the choice, we do associate more lumens with a slight uptick with infection rates. So we default to the least number of lumens necessary. Now, that being said, there's obviously a patient cohort that requires parenteral nutrition 24/7. They might have such difficult venous access that they cannot get blood draws to establish what their electrolytes are, what their nutritional levels are, to allow their nutrition to be modified. And so we may agree that a second lumen is necessary purely to facilitate blood draws. If we do have that conversation, we really need to make sure that the team that is caring for the patient at home and in the physician's office hours, in the clinics, are really top notch, because as soon as that quality slips even the slightest, we do unfortunately see that uptick in infection rates. So if there's even a remote issue that the right infrastructure cannot be assembled to maintain the patient's second access, we will default to a single access to be solely used for nutrition purposes. I hope that answers the question.
Great. Dr. Lookstein, can you talk about the resistance of using AV shunts for TPN and discuss what its uses and benefits might or might not be?
A slightly complex question, but I'm going to do my best to answer it. The first rate is that there is concern that if you are infusing nutrition through an access, that it can contaminate the dialysis machine, essentially making it non-functional, and probably more important than that, preclude the ability to properly maintain electrolyte balance during dialysis. That's one concern. The second concern relates to the issue of access infection. And so if you're introducing nutrition into a foreign body synthetic dialysis graft, there would be, I think, appropriate levels of concern about creating an environment where the AV access could become infected, which uniformly leads to surgical removal of the AV access, which is unfortunately much more morbid than just removing a tunneled catheter. For a dialysis fistula, where it's just an autologous vein, those risks of infection are not as mature. But I think for a patient who has a synthetic graft, I would be very concerned about introducing nutrition through that. If the issue is about, again, introducing it through a dialysis catheter, the same issues come into play about, will the dialysis catheter become infected? Will you preclude a patient from being able to undergo successful hemodialysis? So it's really what the trade-off is. This is not a unique situation. We certainly balance this all the time, but at least currently, we still choose to introduce separate catheters, separate tunnel lines for nutrition and separate tunnel lines for dialysis. And again, I hope that goes to the spirit of answering the question.
Great. We have a participant asking, are patients with SVC syndrome staying symptom-free long-term after central line placement? I have a femoral port to my IVC because of recurrent SVC requiring angioplasty, despite stenting every 3 to 4 months, even after removing all upper body central lines. Do your patients remain successful without return of SVC syndrome?
It's a difficult question to answer. I would say that we definitely have patients that require recurrent angioplasty. That is not routine, but I wouldn't be honest if I said it never happens. I would also say that to generalize, the overwhelming majority of our patients prefer central venous chest access as compared to femoral access. And so we're just very transparent with our patients and say that we can maintain the central veins of your chest as long as you're willing to come in if you're unfortunately one of the patients that do require routine maintenance, and we can make it so that it's a very trivial outpatient ambulatory procedure, perhaps twice a year, but we can guarantee that you can maintain central venous chest access. Most of our patients, if not all of them, choose that as an option, and they do not find 2 visits a year too overwhelming. I would say visits every 3 months is not routine. That tends to be on one end of the bell curve. There are options that we've employed to try and mitigate that, and I think that goes to the issue of covered stents that I alluded to towards the end of my talk.
Perfect. Another question coming in. Many of us have lost typical access. How can we best guide our teams in understanding and using non-traditional access options?
I think that sort of goes to the heart of my presentation. I would say that you need to be seen by a group that is comfortable with these advanced techniques. I don't mean to speak for the entire audience, but our demographic here in New York, our patients strongly prefer to have upper body chest access as compared to femoral or alternative access. And we go through a very, very advanced, in-depth consent process with them, what the techniques that we use, what the workup is, what the expectation is afterwards, what the maintenance protocol is going to be afterwards. And so if you would like to explore options for getting out of non-conventional access, you need to, if not available at your local center, find a center that can offer you restoration of conventional access and engage with them in a very, very healthy dialogue about what their experience is, what the risks are, and then you as a patient need to decide whether you want to pursue that. I do not feel that these techniques are universally available around the country, certainly not around the world, and so you really need to be an educated consumer about finding a site that is employing these techniques, that has broad experience, that approaches it at a protocoled, regimented level to ensure patient safety and optimize patient outcomes.
Excellent advice. That kind of goes along with the next question that just came in is, are the new techniques you have described becoming common across the country, or would vascular surgeons need to be educated about them?
I certainly think there are vascular surgeons that are comfortable with these techniques. As a general observation, any vascular specialist that does these procedures a lot, they are few and far between. So regardless of whether it's an interventional radiologist, surgeon, or cardiologist, I do not think these techniques are universally available at every hospital. I don't think they're universally available at every teaching hospital. So again, you unfortunately need to be a truly educated consumer and make sure that you understand what your local team's expertise is. And if it's not acceptable, you need to seek out a site that is more comfortable with this. I would not presume that your local either radiology group or surgical group are as experienced as either we are at Mount Sinai or the group that I referenced, which is the group down in the Georgetown MedStar region. So these are the two sites in the country that I could reference off the top of my head. There are others that come to mind, but unfortunately, these techniques are not universally available.
Great. Another question, what is the best type of CVD for someone on daily HPN long-term? Portacath or a tunneled catheter?
We default against portacaths. We find that the infection rates are higher than with the more traditional tunneled lines, and that's a local experience. The concern is that removing a portacath is much more morbid for a patient than removing a tunneled line. So we default to a more traditional tunneled line. Here at Mount Sinai, we refer to them as Hickmans, but there's other trade names that can be used, obviously. But ports are really for very, very specific subsets that I think can't maintain traditional tunnel lines. So we have certainly done it, but we tend to frown upon it because of the associated morbidity.
Great. We have time for two more questions. We have one participant writing in. Is there any chance that occlusions are caused by the surgeon or IRMD, perhaps those with less expertise?
I'm not sure I understand the question. I believe, if I were to paraphrase, are these rates of central venous occlusion doctor related? My reflexive response would be no. I think that in centers of excellence, you still see veins becoming occluded. Everyone is grappling with this, and there are numerous technologies that are being explored to try and decrease them. But in the same breath, I would say that if you have a very, very inexperienced team maintaining your central venous access, they will likely abandon conventional venous routes more rapidly than a team of experts, which will understand how to maintain it in the long term. So the other way of rephrasing it is, I would say that teams that are committed to maintaining central venous chest access are more compulsive than comfortable about giving up, and people that dabble in this tend to give up a little bit more readily.
Okay, we have time for one more question, and this has come up in registration and a couple times on the webinar now. Can you swim in a lake with a Hickman?
Yes, but you can shower with a Hickman. You can swim in a Hickman with a Hickman, but you should really be covering, most importantly, the skin access site with a temporary sterile dressing to minimize the exposure. And I would say that you don't want to have prolonged underwater exposure to the catheter. We do have patients that go swimming. They are very, very compulsive about catheter maintenance and catheter hygiene. So it is not for everybody, but I think for patients that have a very, very good infrastructure and are willing to really put in the extra time to make sure that they can maintain the access, there are certainly options.
Great. I think we've run out of time, so we will post answers to the rest of the questions on the Oley website. These are a few pages on the Oley website where you can find resources on vascular access. And thank you, Dr. Lookstein, for an excellent presentation today. We really appreciate you sharing your expertise with us. Many thanks to Shire for supporting this important educational program. Thank you also to participants for joining us today. We'll post a recording of the presentation on the Oley website in case you'd like to view it again. We hope you will join us for another webinar. To view our schedule of upcoming webinars and past recordings, visit the Oley website at oley.org/webinars. That's all for today. Thank you all and goodbye.
Thank you, everybody, for logging in.